afternoon, and welcome to the City Club of Portland Friday Forum. City Club is where we bring civic-minded people together to make Portland and Oregon a better place for everyone to live, work, and play. I'm Karen Curvin, president of City Club. I'd like to welcome members and guests alike, those of you who join us today at Sentinel Hotel, or those of you listening on OPB radio or watching on Portland Community Media. The generous support of City Club's corporate and media partners ensure we put on the state's best civic programs week after week. I'd like to thank our media partner, Oregon Business Magazine. Our current Friday Forum sponsors are Bank of the Cascades, Family Care Health Plans, Legacy Health, Russell Fellow Properties, The Standard, and Stoll Reeves. We are grateful for your support and commitment to City Club's mission. Please join me in a warm round of applause for all of them. We are pleased to welcome back Civic Scholars from Parkrose High School. Civic Scholars is our initiative to expand opportunities for high school students to more deeply engage in Portland's civic issues, bringing civic education out of the classroom and into the community. This morning, prior to the forum, they had their own Q&A with today's speaker. Students, please stand if you are able, and welcome to Friday Forum. We've got several health-related topics coming up in the next few months. On March 18th, we will join the national and state conversation with a forum on vaccinations. At the April 24th Friday Forum, we will discuss the impacts of racism on health, wellness, and genetics. Congressman Earl Blumenauer will take the stage next week to discuss what our region could and should look like when it comes to the new economy, changing demographics, and creating an equitable community. You can learn more about City Club events, purchase tickets, and become a member on our website, pdxcityclub.org. As always, we will be live tweeting today's program. You can follow along and join the conversation using the hashtag PDXCityClub. After today's program, I will facilitate a Q&A session with our speaker. Members, please come to the microphone to ask your question. For all of our audience members, please locate the index cards on the center of your tables and write your questions on them during the forum. Hold your cards up high, and City Club staff will collect them prior to the start of Q&A. I'd now like to welcome Wayne Clark, VP Community Relations at Legacy Health. Wayne is going to tell us a little bit about what Legacy is doing to address health literacy.
Well, one thing we're doing to address health literacy at Legacy Health is in this building on this very day, we are having our 4th annual Health Literacy Conference. 500 people cared enough to take a whole day and come learn about health literacy. And that's the reason your speaker today is here, is that he keynoted for us this morning. I want to share with you just a little bit about what Legacy Health has done in the past 3 or 4 years regarding health literacy by way of example, illustration that it can in fact be addressed and addressed successfully. You will hear something about teach-back technique, I'm sure, before the doctor is done. We've trained 3,900 of our employees in how to use this patient teaching method. And 100% of our nurse staff will be trained by the end of this year. We've created a field in our electronic health record where doctors and other clinicians can note that they did use teach-back. They can document that. Institution-wide policy, by next January, every piece of patient-facing material in our health system will be written at the 6th grade level or lower. That's an institutional commitment. And we've revised many of our documents, including our after-visit summaries, those sometimes tediously long things that you get at the end of a doctor's appointment. So it can be addressed, and we're happy to be working so hard on this and happy to be able to bring Dr. Schillinger to Portland. Thanks, Karen.
Thank you, Wayne. And now for today's program. At least half the population has low health literacy, meaning that they are at risk for worse health outcomes, may not be able to take medication properly, are more likely to end up in the emergency room, and more likely to be sicker when they get there. Often there is a gap in communications between the medical professional and the patient that creates barriers to quality care. Dr. Dean Schillinger is a national expert in closing that gap. He is UC San Francisco Professor of Medicine and former Chief of Diabetes Control for the state of California. He has led projects with diabetic youth that has shown promising outcomes when it comes to health literacy and improving quality care. Dr. Schillinger has authored over 200 publications about this work. He recently co-founded a novel public health literacy campaign with minority youth called The Bigger Picture. Before Dr. Schillinger begins his talk, I'd like to play a video that will give you a glimpse into the work he's done with The Bigger Picture.
Get the money. Mic check 1, 2. Cream, get the money. Cash rules everything around me. Cream, get the money. Dollar, dollar bill, y'all.
Cash rules everything around me. Cream, get the money. Dollar, dollar bill, y'all.
They call me sugar and honey, it's like they really love me. But I'm just looking for money, yeah, just the way they're hungry. Disguised behind dextrin and fructose, dextrose and glucose. Invisible when I'm too close. They advertise me with athletes and celebrities, hidden behind bodies too pristine for my recipe. I'm targeted to low-income teens. Start the habit, spark the addict flowing in your bloodstream. They raise the price on fruits and veggies, but cheapen meat. My mind's too refined, you're blind to the obesity. They undress me, compress me, and then they liquidize. Serve me an ounce is too big in size for little guys. You feel the rush, you're energized. The crash, you're hypnotized. That miniature high is where addiction lies. The ads tell you be happy with your own skin inside, but they fatten you up, I'm still alive by dinner time. This vicious cycle is in your spinal and in your mind. I'm crawling all your hollow bones, I'm killing lives. I'm your neighborhood's pesticide. The safest playground is Mickey D's. Exercise means bigger fries. The food courts are mortified from New York to Uruguay. The average 4 to 5-year-old eats 64.5 pounds of my shit. Cut down and purify. That's the wrong weight in sugar every 365. Disintegrate on your tongue. Euphoria lasts a second. You're soaring and energetic. The orange soda and cola are flowing all through your vessels. I'm slowly an epidemic, controlling the diabetics. Cash rules everything around me. Cream, get the money. Dollar, dollar bill, y'all. Cash rules everything around me. Cream, get the money. Dollar, dollar bill, y'all. I'm born as a crop, harvested harmlessly. Put in the corn syrup, corporations owning me. Sold overly cheap to the store on the corner of the street. Find me in heartbeat, swollen feet and corroded teeth. These corporations are the Mozarts of cornstarch. It's only me on your wood shelves and store carts. The people hate me but need me because they won't starve. In blue veins, I've torn hearts in 4 parts. Cash rules everything around me. Cream, get the money. Dollar, dollar bill, y'all. Cash rules everything around me. Cream, get the money. Dollar, dollar bill, y'all. Cash rules everything around me. Cream, get the money. Dollar, dollar bill, y'all. Cash rules everything around me. Cream, get the money. Dollar, dollar bill, y'all. Cash rules everything around me. Cream, get the money.
Dollar, dollar bill, y'all. Cash rules everything around me. Cream, get the money. Dollar, dollar bill, y'all.
Please join me in welcoming Dr. Dean Schillinger to the stage.
Thank you, Karen, and thank you to the City Club, particularly for showing that video. It's clear that I didn't write the script for that video, right? It's the beauty of working with young people. I want to ask two questions before I start, which is what we just did with the young people who are here. Can anybody just tell me what they felt when they saw this video? What was the emotional response you had when you saw this rap? Just shout something out. Sadness. Anything else? Anger. Condescended to. Okay. Provoked. Provocative. And can anybody tell me what they thought the message this poet was trying to convey? What was the public message he was trying to convey? Sugar's bad. Sugar's a drug. We're being manipulated. Money is driving it. We're being taken to the slaughterhouse, right, in the railroad track. So this is an example, whether you agree with it or not, this is an example of a public health literacy campaign. I'm going to talk really about individual health literacy, but there's a whole other field which this campaign harnesses around trying to improve the public's understanding of public health problems, in this case diabetes, and understanding the drivers of epidemics like diabetes, much like we did 30 years ago with tobacco. So thanks for watching that. I had the lovely introduction, which was all about my official titles, but I'd like to just maybe tell you a little bit more about myself that's relevant to today's talk. I'm a primary care doctor. I'm a general internist, which means I take care of adult patients. And I take care of people on a continuity basis. So I've had some patients that I've taken care of for 20, 25 years. And yet I did my training at UCSF at the university clinic. And then when I joined the faculty, I did my work. I was the medical director of our outpatient clinic at San Francisco General Hospital, which is the public hospital clinic. And the first year of my work as a faculty member was an extremely humbling year because I was taking care of different people than the ones I was taking care of at the university, but they had the same diseases, the same constellation of chronic conditions. But I was having 3, 4, 5, 6, 7 deaths happening again and again. People were having their legs amputated for diabetes. Their heart failure was exacerbated, and they were getting admitted with heart failure. They were having strokes. And I may have had 1 or 2 of those things happen to me when I was in training in my 3 years at the university clinic, but in the public hospital clinic, it was a very noticeable difference. So, I talked to my colleagues about it, and there was sort of this unspoken sense that, there's a lot of social chaos in people's lives. In medicine we call that those people are train wrecks, right? They're out of control, there's nothing you can do, they're homeless, they're IV drug using, whatever, it's just gonna happen and get used to it. I wasn't very satisfied with that answer. Then I went to the textbooks. And it turns out there were no textbooks on this problem of why do we see disparities in quality of care and consequences of care. And then a very important study came out in the Journal of the American Medical Association in 1995, which was my first year on the faculty. And it was a study that showed the prevalence of limited literacy and numeracy skills in America's hospitals. And it showed that about half of patients in public hospital systems receiving care in clinics had only very basic literacy skills and numeracy skills. And for me, that was a really important light bulb because I realized that I had been providing what I thought was high quality care, but what I had really been doing was mostly falling on deaf ears. And it forced me to actually to become a scientist, which I never thought I'd be, to actually research and study communication with patients that you would have thought would have been a well-studied issue, patient-physician communication, but it actually, there was a relative paucity of good research in that field. And sort of started my journey on understanding the experience of having limited literacy skills and numeracy skills, while trying to get health care in the United States. So I'm going to share some of what I've learned in the last 20 years. I'll start off by saying that we're grappling against something here that is multidimensional and gargantuan. In 1971, a British family doctor coined the term the inverse care hypothesis. That was his term. And the inverse care hypothesis stated that access to and quality of medical care is inversely proportional to the needs of the population. Access to and quality of care is inversely proportional to the needs of the population. Now, how did he come up with this stroke of genius? And it actually now is called the inverse care law because it's been shown to be true in many settings globally. Well, it happened because in the National Health Service, as you know, a doctor is assigned a region, right? You get a neighborhood or a few blocks, and those are your blocks, and your job is to keep those people healthy. And if you can do it in 2 hours, that's great. If you need 50 hours a week to do it, that's your problem. You have a neighborhood. And he noticed that in his neighborhood, his assigned population, he was, working from 7 a.m. to 8 p.m. every day. He didn't take Wednesdays off to go golfing like his colleagues seemed to. And he was just, busting his chomps to keep his people healthy. And when he talked to his buddies a few neighborhoods down, he learned that they were working 35 hours. They were golfing on Wednesdays. And so as an epidemiologist, he started to study this. And he noted that the socioeconomic status of the neighborhood in which a general practitioner is stationed is directly proportional to the amount of time that you as a doctor have to work. And there's not enough of me as a doctor, is what he was saying. And so he noticed that the patients in the more affluent neighborhoods were getting more time with their doctor than he could offer in his neighborhood. So when we think about limited literacy skills and healthcare quality and access, we're dealing with a very similar situation, wherein the people who need, in this case, communication the most, often get the least high-quality communication. And I'm going to talk about why that is in a minute. Karen mentioned a few sort of broad brushstroke statistics. So I think we historically have thought about literacy and illiteracy, and that's mostly because of work done in the UN around improving literacy levels across the globe. And in those days and in that work, literacy has been defined as the ability to sign one's name. If you could sign your name, you're literate. And countries who have developed policies that enable, for example, mothers to become literate in that way have seen dramatic declines in infant mortality. And that's been a really important driver of global policy around education. So the field was sort of left with that a number of decades ago until we started to understand that actually there's a whole spectrum of literacy skills. Some people have below basic skills, some people have basic skills, some people have above average, and some people have proficiency. You can think of grade level, 4th grade reading level, 8th grade reading level, 12th grade, et cetera. And so the question that was before us in the mid-90s was, does it matter where you are in that spectrum in a developed country like the United States with respect to health outcomes? And does it matter even if you adjust for socioeconomic status and educational attainment and race, ethnicity, and all the other what we call confounders that we think of when we study things like literacy? And again and again, we found that limited literacy was independently associated, meaning even after adjusting for income and race and all these things, with a number of health outcomes, from how well you understand your disease, how well you can manage your disease, the complications you get from your disease, how well you control your disease, whether that's diabetes or high blood pressure, whether you die from the disease, whether you die at all. The most important study was a study done by one of my mentees who showed in an elderly cohort that having limited literacy skills was associated with a 50% increase in mortality, even after adjusting for income and chronic conditions and a whole range of things. So once that body of evidence started to emerge, organized medicine got together, through a body organized through the National Academy of Science. It's called the Institute of Medicine, that you may have heard of. And the Institute of Medicine in 2004 put out a very important report called A Prescription to End Confusion. And it really put health literacy on the map. Now, at that point, there was a general consensus that this limited literacy and numeracy skills that half of our patients were experiencing, was something that was important. But there was relatively little in the way of answering the question, well, what can we do about it? Which, of course, is what originally brought me to my inquiry when I was seeing that my patients were developing complications of the disease, getting amputations, getting hospitalized, and dying. What could we do? Now, in the field of social medicine, which is this combination of thinking about the social conditions in which people live and the medical care that they get, most of the time we talk about interventions that happen in community. We don't talk about clinical interventions. We think about, okay, if the person has a housing problem or homelessness, we got to get them housing. If they have a drug addiction, we got to get them into a drug treatment program, things outside of the clinic. In this particular social vulnerability, I made the case, as did others, that this is actually something that needs to be addressed in the four walls of the clinic. This is something that is relational. It's something going on between a patient and a doctor or a nurse or a pharmacist, a therapist, for which we have some agency and at least half, if not more than half, of the responsibility for. Because how much you suffer from the problem of the excessive literacy demands of the healthcare system depends entirely on how demanding the healthcare system is. And that degree of demandingness is a function, in part, of how the doctors and nurses and pharmacists are communicating to you. And the kinds of things you get in the mail and from your insurance company, you know what I'm talking about. They are extremely demanding. So we started to make the case that we needed to focus on what the healthcare system could do and what healthcare providers could do to mitigate this inverse care law problem, this relationship we saw between lower literacy skills and higher mortality or worse health outcomes. So we started by, with the hypothesis that it was about communication in the visit. And the first study I did in this regard is actually, not surprisingly, the one that has stuck the most, and actually Wayne mentioned it earlier. What we did was we audio taped primary care physicians talking to their patients with diabetes. And we listened to those audio tapes. We also met with adult educators, people whose job it is to teach adults with lower literacy how to read. And by meeting with those experts, I learned that there are certain techniques that adult educators use that might be important for clinicians to use. The most yeah, I'm going to proceed, unless they don't want me to say it. I don't know. The most important technique is known as the teach-back technique. Can I ask you, just for a show of hands, how many people know what the teach-back technique is? Okay, so about 1 in 5. So the teach-back technique, which actually, if you ask like a first grade teacher, they know what that is, because that's what they do in the first grade. Let's say they'll teach the children the months of the year. And if you sit in your child's first grade class, the first grade teacher will say, okay, class, that was fantastic. Now, who can tell me what the 12 months of the year are? Because I want to make sure I did a good job teaching you. And you know, someone will go January and 3 kids will go February, you know, and then she will have a really concrete gauge of how much they learned from her teaching. And based on that, she'll say, okay, let's, you know, looks like you guys have the winter months down, but like the summer months, because you don't come to school in the summer, you don't know. So let's go back and do that. Okay, that teach-back method is fundamental to pedagogy. Never taught in nursing school, medical school, pharmacy school, nothing. So we audio taped doctors, and we wanted to see among the new concepts, we were only measuring new concepts that doctors were conveying, like starting a new medication or giving a new diagnosis or whatever. How frequently did primary care doctors do any kind of explicit elicitation of patient's understanding, like a teach-back. This is not saying, so have I been clear? Or are we good? We're good, right? That's not a teach-back. Because actually research has shown that that universally is responded with like a nodding head and a yes, doctor. It's not a genuine request for clarification. So it turned out that in this cohort of very good doctors at my hospital who had been hearing my talks, 12% of new concepts had a teach-back method, a new diagnosis or a new medication. Only 12% of the time was there a teach-back. And in those times, the patients got it wrong about half the time, not surprisingly. Doctors' visits that had a teach-back in it were not longer than the visits that didn't. So it's not like we were opening up Pandora's box when we did it. You have 15 or 20 minutes in the visit. What are you going to do with the 15 or 20 minutes? We also found that patients whose doctors used the teach-back strategy, these were diabetes patients, had much better blood sugar control. So that was a very promising finding. It wasn't a study of the teach-back, to see if you did teach-back or didn't do teach-back. It was just a descriptive study, but it was very compelling evidence that this could be efficient and possibly clinically useful. I'm going to come back to the teach-back in a minute. The second thing we did in this study, which shed some light on what is the problem with communication, had to do with medical jargon. So I asked my colleagues, my faculty, do you guys use jargon in your visit? These are all great public hospital doctors. They're like, of course I don't use jargon in the visit. I know not to use jargon in the visit. This is a public hospital. People have lower levels of educational attainment. I would never do that. As it turns out, clinicians have no idea when they're using it, because we speak two languages, but we don't know we're speaking two languages. This is true for all professionals, right? Actually, think about like the IT guys in the back of the room, right? If you started to have a conversation with the IT guys in the back of the room about the computer, they'd be speaking English, but you would not understand a word they're saying, and they wouldn't know that you don't understand a word they're saying, because it's their technical language. So we heard lots of jargon, and we heard not only jargon that was then clarified, like for example, a doctor might say, oh, Mrs. Jones, that sounds like you're having angina. That chest pain in your chest when you're going up the stairs, we call that angina. We heard that, but we also heard, that sounds like angina, we're gonna have to do an angiogram on you. We heard like straight up jargon, no clarification. So another example of a study that you would have thought someone had done, never been done before. So simply measuring jargon. We called these patients back 2 weeks after their visits, and we read them the script of their visit, and we picked the word, and we said, like here was a conversation, a doctor said, I want you to get a new glucometer. It's a diabetes patient. Glucometer is the machine to check your blood sugar, and it gives you the value. So he said, I want you to get a glucometer because it's very critical that I get to see the blood sugar values you're having before we make any medication changes, right? So the doctor's thinking, glucometer, this person's had diabetes for 12 years. Of course she knows glucometer. I've been looking at her glucometer for 12 years. So we call the lady back, no idea what glucometer is. What did the doctor mean? I have no idea what the doctor meant. What does glucometer mean? I don't know. So why would people know what dialysis means? We heard a doctor giving positive feedback to her patient, a wonderful doctor, giving positive feedback for her patient's blood pressure and blood sugar and saying, you know what the #1 cause for kidney failure in the United States is? Diabetes, and you're not gonna need to get dialysis because you're blah, 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 blah. So we call the lady, we're like, what's dialysis? What is doctor trying to tell you? And she's like, I don't know, things are going badly, things are going worse. Like it was all very kind of a scary thing as opposed to very positive feedback. The intent of the doctor was to provide positive feedback, to keep at it, you're doing great. So the teach back, the elimination of jargon, the fact that jargon is actually it's not a teachable moment in the visit. I'm gonna like teach the person angina, like it's just not the right time and place necessarily to be doing that. We didn't see that people learned what angina was when there was an explanation after it. Much in the way I don't learn when the IT guys tell me what's wrong with my computer. I'm like, whatever, just fix it. don't tell me what's wrong with it. So that was the second thing. The next thing was the fact that, you know, people think about literacy as this kind of monolithic reading problem. We now know that actually folks with limited literacy have difficulties across multiple dimensions of communication. There's obviously, you know, the reading and the writing, that makes sense, but there's also the speaking and the listening. And then there's also the numerical, numeracy. And then lastly now, more recently, the digital. 6 connected dimensions of literacy, all of which you can imagine will affect clinical communication. So yes, if I give a brochure that's written at a 10th grade level, it might be difficult for the person to read and understand. But they're also going to have difficulty with my oral communication if I'm using jargon. They're also going to have difficulty with calculations if I'm saying, I want you to take half of your pill in the morning and a pill and a half in the evening, just like that. It's very hard to integrate very quickly for many people. Now, why do people have limited literacy skills? Well, I think the example I'll give is a medical one. If a medical student comes up to me and says, Dr. Schillinger, I've got the diagnosis. It's anemia. And she's all happy. And I'll say, that's not a diagnosis. Anemia? There are 250 causes of anemia. Why does the person have anemia? So medical students very quickly learn that things like anemia, even though they sound medical, actually are not a diagnosis. There's iron deficiency, there's sickle cell anemia, you know, there's just hundreds of reasons for anemia. The same is true for literacy, limited literacy. Why do people have limited literacy? Many reasons. It could be because they grew up in Central America and only got it through the 3rd grade, and then they were working in the farm, and then they immigrated to the United States. So they only had a certain amount of education. I mean, very smart, very bright, but didn't have the opportunity. It could be that they were raised in the inner city in a public school system that was very dysfunctional, and they made it through the 12th grade, but they didn't make it with literacy skills. It could be that they're one of the 20% of Americans that have a learning difference or a learning disability. Now we think of learning disability, oh, dyslexia you mean? Yeah, there's dyslexia, but then there's problems with auditory processing. How many things can you hold in your memory when you hear it? Auditory processing. If you have a problem with auditory processing and I say take 2 pills 3 times a day and see me in 2 weeks, like you're lucky if you remembered about the pills. So learning disabilities and learning differences are ubiquitous, particularly among lower socioeconomic status folks because they couldn't get the good job, and so then they get the chronic diseases, and then they're there in your clinic. And then lastly, cognitive impairment. Now, cognitive impairment, we typically think of, oh, a person's got Alzheimer's or they don't have Alzheimer's. Actually, it's a lot more complicated than that. Many, many middle and older age adults, particularly with chronic disease, have mild cognitive impairment from the effects of their chronic diseases. It could be hypertension, could be diabetes, whatever. You start affecting the small blood vessels of the brain, and I mean, you see it in Uncle John, you see it in yourself, you see it in everybody's, you know, seen it. Some of us have experienced it. Your ability to rapid fire respond and retain and act on information when you have mild cognitive impairment is impaired. And it could manifest as limited literacy or numeracy. So it's very difficult to say, therefore, for someone with low literacy, do this, that, and the other, because people have different reasons for getting there. But the things I'm sharing with you are things that can be universally applied. So we've got the teach back, we have reducing jargon. The next technique, another one where you're like, you mean they haven't studied this before in medicine, is the use of visual aids. I was dumbfounded to learn that visual aids had never been studied in a randomized controlled trial in the United States or globally for any health condition before. So we did a couple of studies of visual aids, and we were able to show that they could improve health outcomes for particular conditions and particular outcomes, but that the benefit of those aids were accrued only for those who had miscommunication, which makes sense. If you're miscommunicating to begin with, then the communication aid should help you. So we now have an opportunity in 21st century medicine to bring visual aids into the room, to bring visual aids into the home with the patient electronic portal. So this technique of using visual aids to amplify and support our messages, I think, is absolutely vital. So we started, we had described the problem, we started doing work around intervening with the problem, and then I thought that, this technology is out there. Can we harness technology in any way? And when people talked about technology and literacy, the immediate thought was, like, that's a night, don't even go there. We developed a technology solution called automated telephone self-management support. It's like interactive voice response systems, those annoying phone systems that you listen to and you press the touch tone to and you get your tickets on United Airlines or whatever. We use that in diabetes outreach and care. And this was in English, Spanish, and Chinese. And the key points about this work were that we partnered with low literacy, non-English speaking patients to create the content. And we partnered with them to test the interface. This seems kind of obvious. We're in the great Northwest and, a lot of computer people. Yeah, user-centered design. Well, actually, very little healthcare stuff involves user-centered design. And those that do not do it with low literacy people. So we use user-centered design principles, and we were able to improve diabetes outcomes, and we improved the diabetes outcomes specifically for the lower literacy and non-English speaking patients, more than for the high literacy English-speaking patients. So we were able to reverse the inverse care law by harnessing technology in a different way, in a new way. So now we have a body of literature around what could be done. And you're probably familiar with this gap between research and policy. And it's been estimated, that there is a 17-year gap when a study is funded by the National Institutes of Health and is completed, showing that drug A cures cancer. Drug A won't be used consistently in the population until 17 years after drug A was discovered and proven to be effective. So in terms of the health literacy research, our concern was the same. Well, are we like a pack of wolves, howling to the moon? Kind of who's listening? And we started to enjoy seeing more and more federal, state, regulatory agencies putting health literacy on the map. I think the most important of all of them was a report that came out from the Institute of Medicine in 2012 called The 10 Attributes of Health Literate Healthcare Organizations. And this commissioned paper really flipped the coin. It was actually called The Other Side of the Coin. It said, let's stop looking at the patient. Can we? Can we just stop, as some people say, blaming the patient? And can we start looking at the other side of the coin? What are healthcare systems doing? As Wayne was talking about for legacy health systems, what can health systems aspire to do? What attributes do they need to have in order to be more health literate and more responsive to everyone? And that was a real signature moment for the field, because it really forced health insurance programs, health systems to take stock, and in some cases take action, not all, to address this as a systems problem. We recently learned that the vice president of the Joint Commission, how many of you know who the Joint Commission is? A few people. So the Joint Commission, anybody in healthcare shakes in their boots when they hear Joint Commission. It's like the Wicked Witch of the West. Oh my God. The Joint Commission is the accrediting body for hospitals. So if you want to be a hospital, you have to pass your Joint Commission audit. You have to pass it, or they shut you down. The Joint Commission just appointed as its vice president David Baker. David Baker was the doctor I mentioned to you in 1995 wrote that paper in the Journal of American Medical Association describing how prevalent low literacy was in American hospitals. So we now have at the Joint Commission a champion for health literacy. So policy has begun to move forward in this regard. Now, we talked about translating research into policy. But you guys, probably a lot of you are policy people. It's nice to make a policy. It's even nice to make a policy with teeth. But that doesn't mean it's changing practice. So I want to give you a somewhat more pessimistic story about that translational gap. So some colleagues and our team got together to tackle the problem of the pill bottle label. About a third to a half of people in America cannot correctly read and interpret a pill bottle label. Take 2 pills 3 times a day. What does that mean? What does that actually mean? Take 2 pills 3 times a day. I know what it means as a doctor, because I know it's in my head, I kind of know it, but it turns out it means about 17 different things to people. And so Mike Wolf and colleagues, we developed what's called a universal medication schedule, which underwent a lot of iterative testing with stakeholders to determine the only way to give prescriptions. And if you're interested, it's take 1 pill in the morning, take 1 pill at noon, take 1 pill in the afternoon, take 1 pill in the evening, take 1 pill at bedtime. Those are only your choices. You can do any combinations of those, but those are your only choices. And that you can get 97% comprehension, and when people are filling pill bottles, they'll get it right 97% of the time if you use that. And that's true in English, Spanish, Korean, Chinese, and Russian. We got a bill passed in California to change the pill bottle labels from the pharmacy board to have the universal medication schedule be used. So we got research, we got policy. So now I'm in my hospital, and it's time to make this happen. And we've been unsuccessful for over a year. We have an electronic health record that does not let us restrict prescribing instructions. It says, sure, you can include that as one of the 196,000 prescription choices you have for a medication instruction. But that's not going to change a physician's practice. If you got 196,000 choices, you'll put whatever you used to put. It's not going to change anything. Second, the visible language in the column of the electronic health record is only like 17 figures long. So you can't, if you say take 1 pill in the, that's what it says. Take 1 pill in the, you're the prescriber. You can't see. These are silly problems. But the devil is in the details. The policy is great, but so this is crazy. So I call up our electronic health record and our vendor, and I won't say it here because I'm on the radio. But they say, oh, we can't change that. We don't control that. I'm like, okay, we pay you like whatever, $17 million a year. You don't control that. Okay, who does? Well, there's Medispan is another company. They control the framework on which the prescriptions are written, and SureScripts controls the content. So it's like 3 entities, none of whom have a stake in the patient, that have to agree to do a workaround for our little hospital. Never going to happen. Not going to happen. So when we talk about health literate health systems, we really need to think about the whole system and find ways to engage the big players in this problem, because this is a very costly problem. You know, over 700 billion it's been estimated. I mean, I don't even know what to believe anymore. Huge amounts of money being spent on errors, mistakes, complications, et cetera, because the health system is not designed for common people. So that's my challenge. I think that's all of our challenge, is to take the understanding that most people in America are not proficient enough in medical speak to be their own doctors and nurses and run their own intensive care units at the bedside, that most doctors and nurses and pharmacists and everything want to do better, but don't have the skills, don't feel they have the time or the support, and certainly don't have the systems and frameworks in which they're working to do the right thing, and that most payers don't seem to be that interested in it just yet. And that's got to change. So I'm going to stop there, and I think we take questions, right? Thank you.
Thank you, Dr. Schillinger. That was really interesting. And now, if you have a written question on an index card, please hold it up high so that a City Club staff member can collect it from you. We will now take questions from the floor. As always, we invite members to the microphone to ask their question. Asking questions at Friday Forum, microphone is a benefit of City Club membership, and membership is open to everyone. Before asking your question, please identify yourself as a City Club member. Please ask only one question and ask your question as succinctly as possible. If I flash the dreaded question mark, it means please wrap up your question. Go ahead.
My name is Reed Ripsum. I'm a student at Park Rose High School, and I wanted to ask, how might you reform the American healthcare system to improve health literacy? And are there ways to make the same health information available to all economic and social classes in our current system?
Thank you. And you are 17 years old, right? Something like that. The question was, how would I change the healthcare system to be more health literate? And I think relatedly make health information more accessible. So I think it starts from a very fundamental perspective, which is, can we design the delivery of services in such a way as to reverse the inverse care law? By that I mean, if you look at my city, the neighborhoods where all the poor people live are served essentially by one public hospital system, and my clinic is packed to the gills, the pharmacy line is out the door. If you go north of Market in San Francisco, there are like 3 or 4 or 5 hospitals, and you go in the waiting room and it's like, oh, it's lovely in here. I'll just go get my blood test and I'll come right back, and so there is a problem with how we distribute health and health care in our society. That's true in every society. That's not unique to our society. What is unique to our society is our unwillingness and our blindness to dealing with that and to engineering and hardwiring ways to accommodate that. So that a rational system would say, well, if there are 10 times more people with diabetes in the southeastern corner of the city, maybe we should have 10 times more clinics in that part of the city. And that the healthcare system needs to create the economic possibility for that to happen. The second part of the question is about the health information. I can't but believe that the vehicle for communication in the future of healthcare is going to be the computer. It's going to be the between-visit communication that we have with our patients. Hopefully it won't rely on the written word, it'll be more in the narrative form, but I think we need to start to create content that is co-created by the folks who need the communication the most. Right now, even, there are some exceptions in the patient education world, but most of the content is still created by doctors and nurses and health educators, and it's not really very patient-centered. So if we could create truly patient-centered content that provides more information to people who want more and less to people who need less, that would be great.
Hi, my name is Mara Angela Cervantes. I'm a Civic Scholar from Park Rose, and my question is in relation to what we talked about during the Q&A. How does a high schooler like myself take control of our health and nutrition when we're so dependent on our parents' low income?
So the question from another 17-year-old, is that right? How does someone take control of their health and nutrition when we're so dependent on the low income of our parents? So the first thing to say is, you're asking the question. So that's like 99% of it. The second thing is just to point out what you've stated, which is that these issues of social problems, whether it's literacy or income or violence or transportation problems or housing, they cluster together. It's not like most people only have one thing. They come together. And so often kids and adults are grappling with multiple competing challenges, not even health challenges, to live life. And then you throw a health challenge on top of it, and it's very difficult. Now, all this talk about vulnerabilities and risk factors and all that stuff is pretty, negative. And the truth is, while low income places you at higher risk of diabetes, let's say doubles your risk of diabetes, the chances are really high that you're not going to get diabetes, because there are a lot of positive things going on in your life too. And so for you, it's to think about what are the beautiful and wonderful things in my life and in my community, and how can I take from that? What can I take from that? What can I give back to that to make us even more resilient than we already are? Because you clearly are. I mean, you're here, you're at the City Club, girl. I mean, you're resilient. So I think it's to, not ignore the negative stuff, but really try to accentuate all the good things, and to be around people who are also making you better. Now, with respect to the specific question about low income and risk, well, I can tell you it is cheaper to drink water than to drink a can of Coke. It actually is. And, I know, you're also eating food that is heavily salted, purposefully salted heavily, so that you're thirsty, so that you buy the drink. So it takes a lot of steps to drink the water. But I think there are daily decisions that even low-income people can make and do make and help each other make to not have the low income be, a death sentence. And then the last thing I'll say is, and this is a story from Jack Geiger, who was the founder of community health centers, and he went in the 60s to the, to the outskirts of Johannesburg, where things were just in South Africa horrible, right? And he went there to try to fix things and, improve health. And he was talking to a girl your age, and he's like, you got to do this, and you got to do this. And she said, no, I don't. I got to get the hell out of here. He's like, you're right. How can I help you get the hell out of here? So sometimes you got to get the hell out of there. And for you, you're gonna get the hell out of there, because you're on the path. And it's not to say you're not going to go back, but you're going to be a success story for your family.
Hello, I'm Jade Bradford. I'm with the Civic Scholars program from Parkrose High School, and my question is regarding diabetes among the ethnic minorities. So, aside from economic status and education, which would mean being able to afford good quality foods and knowing what proper dietary concerns are, is there anything in our genetic makeup that causes African Americans to be more susceptible to any form of diabetes?
Is that a trick question? The question is, I'll actually tell you a little story. The question is there anything in the African American genetics that makes us prone to diabetes? And it's a reasonable question to ask, because a lot of people say, my mother has it, my grandmother has it, my grandmother has it. There is a video in the Bigger Picture campaign that I would encourage you to watch that's called Death Recipe. And it's a story, a poem that an African American girl created, wrote, and performs, and her first line in the poem is, "We eat like we still slaves." So, and what she's saying there is, we've been eating like this for 300 or 400 years. So, what's this whole family history thing about? The other story I'll tell you is I recently interviewed the former chief of pediatrics at Sanford General Hospital, a 98-year-old guy. He's like 4'10" now, and I asked him, Moses, his name's Moses, do you ever remember there being type 2 diabetes in your clinic when you were at the hospital? I said, type 2 diabetes? No, of course not. I said, well, you know now, like 40 years later, you know, it's pretty common in the teen clinic at Sanford General Hospital to have type 2 diabetes. And he said to me, this is a progressive guy, oh, well, the genetics. And I said, Moses, like, you just told me 40 years ago you didn't see a single case. And 40 years later, we're seeing it, and you're telling me genetics? I don't understand that. So I think we are conditioned, so deeply conditioned, to think about genetics when we see racial differences. Because we think the fact that you're brown and I'm white means that we're genetically like incredibly different, where in fact that is actually not the case. The science around the genetics of type 2 diabetes is in its infancy. We know it's a polygenic disease, meaning it has multiple genes that contribute to its manifesting itself. It's not one gene like sickle cell anemia. And there's really not been a lot of evidence at all to suggest that blacks are genetically susceptible to diabetes, or Latinos, or, you know, whatever. Now, that's not to say that under the right conditions, like a high fructose corn syrup environment, certain genes can't get turned on more frequently among certain people than other people. We just don't have the science to do that, and I'm not sure that's the first place to go scientifically, but I'm sure there are people doing it.
We have time for one more question.
Thank you. Sam Chase, City Club member, Metro Councilor, and also director for a coalition of safety net clinics in our region. And the number one reason that children, I'm toxic to this microphone, I think. The number one reason children miss school is because of bad oral health in our region. Oral health. And what can some of our primary care clinics, our safety net health clinics, be doing to improve oral health prevention strategies in our clinics?
Am I on the mic here? So the question was, a lot of our kids miss school because of oral health problems, and what can we be doing in our communities and in our safety net clinics? Okay, so this is like simple country doctor answer, okay? I'm obviously not an oral health person. I have worked in oral health, particularly as it relates to diabetes, because the two go hand in hand. And I can tell you a little bit of what I've learned. The first thing I've learned is that the application of fluoride varnish in preschool children, which is exceedingly simple to do, exceedingly cheap, does not require a dentist to do, can statistically and significantly lower the incidence of cavities in school-age children. And every county and community should have a fluoride varnish program. That's a very effective preventive measure. It's not to say you should only do that and not teach parents what not to do. Obviously, there still are a lot of parents who are unaware that giving people juice in a bottle, giving children juice in a bottle is going to be bad for them, and so there have to be programs that are kind of wrapped into other social services like WIC programs and Head Start and those sorts of things that, not in the clinic per se, but in the other places in which people live their life, to try to root in some healthy practices. And then I think some of the other public health measures we need to do, which is to reduce the consumption of sugary beverages in general for the entire population, will have tremendous benefits then to children who are disproportionately consuming these beverages. I think it's got to be a public health approach. I don't think every child needs a dental exam at age 5 intervention is that sustainable or that effective.
We have run out of broadcast time for further questions, and we'll have to stop for the day. As we close, please join me in offering our sincere thanks to Dr. Dean Schellinger.